greetings everyone. Welcome to the 161st session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Avani Dave. Dr. Dave received her Bachelor's of Science degree with honors from the McMaster University. She then was awarded the Presidential Scholarship to attend the NECO, which is the New England College of Optometry, where she earned a doctorate of optometry degree. After graduating, Dr. Dave also completed a residency in the Cornea contact lens and at the New England College of Optometry as well, and was able to focus on specialty contact lens fitting and managing corneal diseases through her training at the Massachusetts Eye and Ear Center, which is also the Boston Foundation of Sight. I think she also worked there at the Boston Medical Center and the Ophthalmic Consultants of Boston. Currently, Dr. Dave practices in 2 countries, in the United States, in New York at Buffalo, and also in Toronto, Canada. She's the director of the Optometry and Contact Lens Services at the University of Buffalo's Ross Eye Institute. She is also a clinical instructor of the ophthalmology. Dr. Dave is involved with lecturing residents. She enjoys teaching through her role as a clinician, as an academician. She is the fellow of the American Academy of Optometry, and currently she is pursuing her fellowship with the Scleral Lens Education Society. She is also the recipient of the Johnson & Johnson Vision Care Award of Excellence in Contact Lens Patient Care. And today, Dr. Dave is going to take us through her experience about neurotrophic keratopathy, how to manage these patients with her case series as well as her experience. So welcome, Dr. Dave, onto our platform. And let me just leave this screen time to you.
Perfect. Thank you so much, Fakruddin, for a very great introduction. And Happy New Year to everybody. Thank you all for joining. I'm excited to chat about this hot topic in the eye care world, which is neurotrophic keratopathy. And it's been an emerging topic over the past couple of years, underdiagnosed in my opinion, and a lot of new treatments that have been recently approved worldwide over the past couple of years. So let's get started and plan for this painless problem. Here are my financial disclosures, and let's kind of start off with the goals for today's lecture. So neurotrophic keratopathy manifests in various clinical forms, and so my goal is to review the clinical evaluation and how to identify neurotrophic keratopathy. Second is that we'll go over diagnostic screening tools. In my opinion, neurotrophic keratopathy is largely underdiagnosed, and the key in the successful management of neurotrophic keratopathy is to diagnose it earlier so that we can prevent the disease from progressing. So screening tools and evaluation are important in that. Third is we'll go over current treatment and management options, some new, some old, traditional that work well for ocular surface conditions. And lastly, we'll go over some of my own case discussions and examples where I have been able to pull all this information together. So with that, let's get started with a poll question. I know that we have a large audience of both students, clinicians, academics, and so the goal here is how confident do you all feel in identifying, treating, and managing neurotrophic keratopathy? Walker, then a lot of people fall in that middle category right off the bat. And you know, to sit here and say you feel very comfortable at NK is something that I even also have to question myself because there's so much new information coming out year by year. So I'm glad to hear, you know, it looks like majority of our population in this chat today or in this lecture series is unsure, and it's all about learning on the go, and that's why everyone is here joining us today. So let's continue that learning. So with that, let's talk about neurotrophic keratopathy. So as the name suggests, the NK, which I'll often refer to in this lecture, is a role of impaired corneal healing due to either decreased or loss of corneal sensory innervation. So NK, neurotrophic, meaning loss or decreased sensory innervation to the cornea, keratopathy leading to corneal disease. So with the reduced corneal sensitivity, what we have is reduced reflex tearing and a reduced blinking rate. As a result of that, we have reduced reduced lubrication and epithelial healing, which therefore then makes our ocular surface susceptible to corneal injury. And oftentimes we think of corneal injury as the environment or a foreign body, but in NK, simply just that action of the upper eyelid blinking and that friction can cause corneal injury, considering how fragile the surface becomes. So there's a lot going on this slide, and I know it can be daunting. I find that with NK, we're merging ocular surface in the cornea with neuro-ophthalmology, which can seem like two different paths, but this is the one condition where we have to think about both. So when you think of the corneal anatomy specific to the nervous system, we know that the cornea gets innervation through cranial nerve number 5, which is the trigeminal nerve. If you all draw your attention to the picture up to the right-hand corner, we have the trigeminal nerve that supplies 3 branches, and primarily to the ocular surface, we're thinking about the ophthalmic branch. Now, the image on the left here shows that the ophthalmic branch actually splits up into 3 branches furthermore, depending on what we're innervating. And so specific to the cornea, we're focusing on the nasociliary nerve, but the frontal and lacrimal nerve play a role in a lot of adjacent tissues. And we'll talk a little bit about why it's important to know that ongoing. So the cornea is very sensitive, and we all know that. And as these corneal nerves enter on the stromal level, they end up coming into the circumferential aspect and protruding upward towards the surface. And oftentimes what I would just explain to patients is that a single prick on the cornea is equivalent to a whole palm on your chest. And that relative comparison can be shown that there's about 7,000 nociceptors or pain receptors on the surface of the cornea per millimeter squared. That's about 400 times more than the skin and about 100 times more on the conjunctiva. So that sensitivity is very, very elevated. So now if we think of our sensory innervation, we know it's our trigeminal nerve through all the branches. And so how does that play a role on your ocular surface? So there's 3 main aspects. There's the trigeminal nerve that is causing tear production. So through the innervation of tear production, we have this basal tear secretion that's providing that surface comfort as well as lubrication. The second is the blinking rate. So the blinking rate is this basal protective action that's promoting the protection of the ocular surface, but also the generalized wiper effect that's happening on the epithelium. Third, and this is probably one of the most important when it comes to epithelial integrity, is the production of trophic factors. So these can be diffusible or soluble factors produced in not only helping with epithelial cell turnover, but also protecting the epithelium from damage. And this is done through the role of neuropeptides and cytokines and neurotransmitters, as well as growth factors that we'll chat about more a little later. And all 3 of these mechanisms are what are promoting the corneal epithelium from breaking down. So then, if we think of the pathophysiology of NK, well, we know that our lacrimal gland is crucial towards tear production. We have our trophic factors that are crucial towards the integrity and maintaining the epithelium. Our limbal stem cells are crucial in our epithelial turnover that's happening from the limbus towards the center of the cornea. And so as a result of that, in NK, when we have reduced innervation, all 4 of these functions are reduced. And so as a result of that, with decreased innervation, we have our corneal epithelial cells that will end up going through swelling. And then through swelling, there is the loss of microvilli, abnormal basal lamina, and that stops the process of mitosis, which leads to epithelial breakdown. And so if we think of the epithelium, it's a very rapid process, can take, simply even a day, depending on how small the epithelial injury is. But what's crucial is to remember that it takes about a week or over a week to really have those hemidesmosome connections to the epithelium adhere to the cornea. And so the more epithelium breakdown you have, the more susceptible injury you have to deeper layers to the cornea. So let's think about etiology. And, majority of us are either students or clinicians on this call. And so we're all used to taking patient histories and knowing what risk factors to look at. So if you think of these risk factors, we can break them down into 5 categories. So first is the central nervous system. Because this is a neuropathy, we have to be able to identify certain nervous system conditions or lesions specific to the brainstem. Post-neurological procedures, trigeminal neuralgia is a very common one, which is associated with pain surgery. An aneurysm, whether it's clipped, coiled, or even bursts, can impact the nervous system route. Neoplasms, as well as stroke, so some type of ischemia. And lastly, degenerating disorders affecting the nerves. So central nervous system is key, but then we can move on to thinking about systemic conditions. So the most common systemic condition that I think we all are used to seeing, especially in the eye care field, is diabetes. And diabetes is associated with neuropathy, especially peripheral neuropathy, but it can also be associated with NK. So leprosy is another condition to think about, vitamin A deficiency, acoustic neuroma surgery, especially because the bundle of nerves and vessels are all interconnected. Then multiple sclerosis is also another demyelinating condition to think about when it comes to NK, amyloidosis as well. Moving on, there's some genetic conditions that can really impair the neural connections, specific trigeminal and facial nerve. And so Riley-Day syndrome, Goldenhar syndrome, Mobius syndrome, as well as familial corneal hypothesia. So any of their patients that have these genetic conditions, always look and test for NK. Next, ocular. So this is probably the topic that we're all very well versed with because this is what we love to look at. And so when we're thinking of the ocular risk factors, any form of herpetic disease, I strongly urge you all to always check for corneal sensitivity. Next is any type of corneal nerve damage or injury. Topical drug toxicity. So when I mention this, I mean both toxicity related to prescribed medications. For example, our glaucoma medications. A lot of our medications include BAK as preservatives. Diclofenac or NSAIDs are also commonly associated with corneal injury. And then on the flip side, there's also abuse of topical drugs. For example, anesthetics. So we always know proparacaine, tetracaine, or any type of anesthetic to the cornea for long-term use can cause corneal melt and injury as well. Contact lens wear. So this is probably the most common route where NK goes underdiagnosed, because think of how many contact lens wearers there are out in the world and how many years they've been wearing contacts for. How many of us look for corneal sensitivity? Some thought to ponder for that. Next, chronic ocular surface disease. So your dry eye patients, our Sjogren's patients, our Stevens-Johnson's graft versus host disease patients. Corneal dystrophies, depending on the layer of where these dystrophies are impacting. And so generally, anything on the ocular surface that's impacting your corneal nerves or your epithelial layer or ocular surface integrity is going to create some concern for NK. And our last category is trauma. So trauma, typically we think of facial trauma. And in many cases, if you think of a Bell's palsy patient, you're going to have just one aspect of the face being impacted. Chemical burns or injuries are also very common with NK. Radiation therapy. In Buffalo, New York, I work next to a renowned cancer institute. And so for a lot of my patients that are going through chemotherapy as well as radiation, what I'm concerned for is to see what their ocular surface looks like and how their pain threshold matches with that. Fourth is any form of ocular surgery. And we can kind of split this up into different categories. So refractive surgery and corneal surgeries, whether it's a simple LASIK, PRK, or SMILE versus a full thickness keratoplasty. Glaucoma surgery, so if we're thinking about any impact on our ciliary body, which is also involved with the production of our TM or our intraocular fluid, can also impact the general nerves that are connected towards that route. And then, of course, retinal surgery, so photocoagulation and any type of laser can also further on put the patient at a higher risk for NK. And lastly, orbital surgery. We know that the nerves and vessels are all connected in and around the globe. And so thinking about the nerves that are being impacted in the orbital surgery are also very important. So I keep talking about the ocular surface and the eyes and then going back to the nerves. And so while I'm not a fan myself of neuro-ophthalmology, what we can think of is, if you think of your risk factors for your patients or the etiology, you can also break it down into the route of the nervous system or the nerve course towards the cornea. So any lesion, injury to the brainstem, or any concern for any type of brainstem damage can lead to LK. And then if we follow that course to your trigeminal ganglion and seeing the splitting of the nerve fibers from there. Third, the ciliary area. So the ciliary nerve and ganglion are also important to think about. Then the ocular nerve, or the course of that ocular tract. And then lastly, down to our corneal level. And so any of these levels on a nervous system basis, if there's some type of compromise, then down the line, what we need to always look for is NK. So now let's talk about how exactly we screen these patients. Early diagnosis is key. And, when I was preparing this lecture, I was looking at different prevalence amounts of NK in the world. And uniformly across the literature, while the numbers are very low, the consensus was that it's probably going underdiagnosed because we're not screening for it as earlier. And so let's talk about screening details. So first, our patient history. And really isolating the etiology can be found before you even put your patient behind the slit lamp through the patient history, kind of heightening your senses to look for NK. Second is our slit lamp evaluation. Third is tear production. And for me, Schirmer's testing is very important. I say this to always try to do it without the anesthetic. And the reason why is because what we're looking for is a basal layer of tearing without the reflex tearing involved. However, in NK, we also want to check to see, with that anesthetic component of the corneal nerves, how that tear production is impaired or affected. Next, corneal sensitivity measurements. There's qualitative and quantitative measurements that we'll talk about. And lastly, while not used frequently, corneal nerve imaging can be very helpful when you are monitoring your patients. So first and foremost, as providers, let's talk about the slit lamp. So we've had many patients that we've put behind the slit lamp. We look at their cornea. It looks like a disaster, and we pull that slit lamp away, and we ask the patient, how do you feel? And the patient shrugs their shoulder and says, I feel great. And that discrepancy between the symptoms and the signs are classic when it comes to neurotrophic keratopathy. So first and foremost, I always assess the lids and the lashes, looking for lid anatomy, looking for debris, extensions, or makeup on the eyelids, blepharitis, looking at the quality of the eyelids, so floppy eyelids and easily avertible, or also the tension of the eyelids. Next, I'm looking at the conjunctiva, and we'll talk a little bit about the use of dyes in the conj, but chalasis as well as signs of allergy can be very indicative of the inflammation levels in the ocular surface. And of course, most importantly, the cornea, and this is where looking for staining and scarring is important. Lastly, I encourage you all to take a step back and looking at the blinking function as well as the rate of the blinking. So moving on from the actual utility of the slit lamp, let's think about the use of dyes. And I think traditionally, we all think, well, fluorescein will identify any corneal impact, which is true. When I think about fluorescein, what I want to see is how is my epithelium as well as my tear film looking. So I'm looking at both frank staining as well as breakup time. But what I find is that the quality or the amount of staining and the staining location can help differentiate dry eye disease versus neurotrophic keratopathy. So what I find is any type of inferior staining is more traditional with ocular surface dryness, whereas more diffuse or central staining is associated with NK. In addition to that, I encourage you all to also pull out either rose bengal or lissamine green, because the helpful role of these dyes, while can be slightly more toxic, is that it helps you identify desiccated cells. So here we're looking at staining on the conjunctiva, on the lid, and you'll be surprised as to how much lissamine green staining you can pick up on the cornea. And so again, the quality of the staining and the location of the staining is very important to document. Now, when we think of rose bengal versus lissamine green, I traditionally use lissamine green only because I find that it's less toxic and better tolerated for my patients compared to rose bengal, especially if the patient already has some concurrent ocular surface disease. They're going to be very sensitive. And so that burning effect from the rose bengal ends up throwing off some of my assessments. So this is a patient of mine that has limbal stem cell deficiency, has worn contact lenses for many years. When I did corneal sensitivity testing on her, found that she actually had a much reduced response, and so diagnosed her with NK. And on one side of the screen, I have the lissamine green staining. On the other, I have the fluorescein, and I've put up a Ratten filter to help kind of identify the fluorescein. So while I don't have any frank staining here, what you can see is kind of this ridge of the limbal stem cells kind of protruding towards the center. And when the patient's blinking, you can see areas of irregularity on that tear film. Now, interestingly enough, when we take a look at that same area on the left with the lissamine green, we're seeing some pickup of staining along that ridge, which tells us there's some desiccated cells there too. So I encourage you all to use both types of dyes. So the question now leads into, we know how to identify our patients based off of their history. We all know how to use the slit lamp, but how many of us are actually looking for corneal sensitivity on your regular day-to-day practice? And I will admit that prior to really being passionate about neurotrophic keratopathy, in my own scleral lens patients, I myself was not checking corneal sensitivity very frequently. My goal for today's lecture is to encourage you all, and it looks like from the poll itself, about 66%, 68 now, rarely check for corneal sensitivity testing. And so this is, again, another contributing factor to earlier diagnosis of NK and why I think it goes underdiagnosed very frequently in our clinical practice. So let's talk about how to go about corneal sensitivity. And there's multiple methods. First, we have the cotton thread method, which is more of a qualitative method. Here we're looking at normal, hypo, or decreased reaction, as well as no reaction, which is considered anesthesia. Now, the difficulty with the cotton thread method is that it's up to the subjective nature of the provider to describe the response of the patient. Next is the Cochet-Bonnet, which is more of a quantitative measurement. And we'll kind of show a video as to how this is done. A nylon filament is then probed onto the corneal surface, and the length of that filament is measured. So it gives you more of a quantitative approach. In neurotrophic keratopathy, the most crucial area to always check in the cornea is the center. And we'll kind of go over how I check in my own practice. And then lastly is non-contact or gas aesthesiometers. And what this is an addition to your slit lamp that's an air emission, kind of similar to our NCT machines when we're checking for IOP. Now, the beauty of the non-contact version of this is that there is no physical reaction on the cornea, but we have this air emission, and we can control it to look at mechanical, thermal, as well as chemical responses of various degrees or factors. So I'm going to highlight really the main two that I have used in my practice. What I typically do for these patients is I'll use a cotton thread and I'll pull the edge of the cotton thread or the Q-tip so that I have a very thin wisp that's remaining. Now, an alternative to the cotton swab is you can also use unwaxed dental floss or a tip of a tissue to elicit the same reaction. And so what I'm looking at here is really the 4 clock hours. So 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. And as I am really kind of using that cotton swab to elicit a reaction, I'm looking at the patient's blink response for both the upper and the lower eyelid, as well as their general response. And next, I'm also looking at the central cornea. Looking at the thread and really just bringing it close to the surface of the eye, I like to isolate visual response from the actual corneal response. So oftentimes when I'm looking at 12 o'clock, I'll have the patient look down and I'll probe that 12 o'clock position and look at how the eyelids are reacting. And then, of course, the central cornea, the moment you bring that thread close and kind of apply it to the surface, looking at that general response, the more you do the cotton thread method, the more you'll get a gauge as to what's a normal response, a hypo response, or an anesthetic or no response. So next is our Cochet-Bonnet esthesiometer. And what this is more of a quantitative measurement. So the way this filament works is we have 0 to 6 millimeters or centimeters of measurement. And so the longer the filament, the more flexible it becomes, and so the more sensitive the cornea is. And so depending on the degree of the patient's response with the length of the filament, you can record that as a quantitative measurement. And I encourage you all to not only check the central cornea, but to split it up into the 4 different quadrants as well, and isolate this when you're documenting it on your chart. Again, we know with NK, the central cornea is the most important. Next is corneal imaging. And while I admit I personally use more imaging for the corneal endothelial cells, I think what's helpful is that we have the ability of high resolution assessment of corneal nerves at the different layers of the nervous system within the cornea. And so from our epithelial, our subbasal, subepithelial to our stromal layers. What's interesting is through confocal imaging, what you can appreciate is the striations of the nerve bundles and also beating on the bundles or the density of these fibers to isolate normal versus neurotrophic or loss of these corneal nerves. And what's also interesting is to look at the directional orientation. So we all know that at the limbostromal level, the corneal nerves are entering the cornea. And then what they do is they're on a circumferential horizontal path and then start going into these vertical striations right towards the center. And that's why I think checking for corneal sensitivity in different quadrants is also very important based off of, that finding. Next, now you're suspicious of corneal sensitivity being impacted, you're suspicious of NK, let's now classify it. And so the Mackey classification is a universal classification as to determining whether you have stage 1, mild, stage 2, moderate, and stage 3, severe. So let's break down stage 1 first. Stage 1 NK can present in different forms, but unanimously across the board, what you're looking for as far as symptoms is maybe some dry eye symptoms at most, blurred vision, photophobia, as well as a reduced blink rate. When we apply that dye on the surface, what you'll see is more staining, and we talked about differentiating dry eye staining at the bottom versus diffuse staining. We do not have a presence of epithelial defects in large size yet, but there is a possibility of neovascularization that might be present, and really looking at those limbal stem cells too. In the tear film level, what we're looking at is staining with our rose bengal or our lissamine grain, reduced tear breakup time, tear meniscus height, as well as the general consistency of the tear film. So seeing that frothy mucus debris in the tear film can be indication of the tear film breaking down furthermore. Stage 2 is when we have further decline of blurred vision at most. Patients are, if they are anesthetic or neurotrophic, they won't have any other pain symptoms. But when you apply the dye, what you'll see is these classic oval-shaped, rolled-bordered edge defects on the epithelium. And what I encourage you all to do is apply the fluorescein and watch it. See how those edges and the fluorescein leaks through, possibly past the edge of those borders. What we're looking at when it comes to epithelial defects, always look at the superior cornea with the upper eyelid, creating that overall friction, because due to that friction, with the epithelial cells already being a little fragile, you can have a lot of acute loss of epithelium up on that area where the upper eyelid is frictioning over top of the surface. At this point now, we have potential damage to the Bowman's, and the stroma is susceptible to damage. On the tear film, now we have more inflammation and more hyperosmolarity occurring. For stage 3, this is where our stroma gets involved. And so at this point, the concern is stromal involvement as far as scarring and thinning. And the biggest concern for us is preventing the patient from encountering corneal melt or corneal perforation. So this is severe in terms of our role as providers. On a tear film level, we have just an abundance of increase of inflammation, as well as MMP9 activation that's chewing away at the cornea. So now that we are able to identify, screen, and diagnose NK, let's talk about the management overall. And so the treatment of NK is completely based off of the staging. So the goal of the treatment in stage 1 is to prevent the epithelium from breaking down and leading into stage 2. And stage 2, once you already have an epithelial defect, the goal is to promote healing and prevent an ulcer from occurring. And on stage 3, the goal is let's prevent the corneal perforation and reduce the stromal scarring from happening altogether. So then if we think of the management, and I really have to attest a lot of esteemed corneal colleagues in North America that have come together over the past couple of years and gone over case discussions. There's a group over at Duke, there's a group over at New York Pioneer. And so this case, or this slide really comes from a lot of consensus in the cornea community. But if we break up management, we can think the first role is topical. So preservative-free artificial tears and lubrication is important, using our gels and our ointments, but those that are gentle and not toxic to the surface. Using our immunomodulators, so the cyclosporin or lifitegrast, which is the Restasis or Xiidra here in North America, serum autologous tears, as well as cytokine tears, German or Oxervate, which was recently FDA approved, as well as intranasal stimulation. We'll talk a little bit more about some of these topics in details. Next is systemic management. So here we're thinking nutrition. So vitamin C plays a huge role in preventing corneal scarring and promoting corneal healing. Our omega-3s in reducing inflammation, tetracyclines, as well as macrolides, and antiviral therapy as well. Third is thinking protection. So we want to protect our ocular surface, knowing that we're neurotrophic, from breakdown. And so in that role, we think of bandage contact lenses or scleral contacts as a therapeutic role. Amniotic membranes, we'll talk a little bit more about this in detail. Tarsorrhaphy, temporary tape tarsorrhaphies, Botox injections, as well as lid weights to induce ptosis, which naturally then is protecting the ocular surface. And of course, lastly, punctal plugs. And then lastly, we think of the surgical role and co-management with our ophthalmology community in punctal cautery, sutured amniotic membranes, complete or partial tarsorrhaphies, and most recently, as of 2018, there's a lot of data with direct neurotization. There's a group in Duke that's doing some great work in the role of direct neurotization of the ocular surface nerves overall. So let's first talk about serum tears. Serum tears can be both autologous and allogenic, one being that the donor and recipient are the same, the other being the donor and the recipient are not the same but can be serologically matched. And so the way serum tears are composed is that the blood is drawn and thrown into a centrifuge. And the component of the blood that eliminates a lot of the platelets and clotting factors is the serum that's left behind. And then that is prepared with typically a preservative-free artificial tear into vials of serum tears, which are then utilized on the ocular surface. The general consensus is that serum tears have some excellent properties for corneal healing. And this is through the role of some of the inflammatory or anti-inflammatory mediators and health factors for the corneal epithelium healing. But the difficulty with serum tears oftentimes is the access. So the cost of access in North America, there's quite a few labs that are really helping aim at improving the access to care. Second is the difficulty of acquiring through finding a phlebotomist to draw the blood or a lab to draw the blood. The third is composition varies across the board. And I don't necessarily find that for NK specifically, there's a consensus as far as the serum to tear ratio. It can range anywhere between 20% to 100%. Furthermore, dosages can differ. However, traditionally across the literature, for NK, the serum tears are dosed at 6 to 8 times a day for the first month, and then tapered to 4 times a day for an ongoing dosage. But because this is a blood-borne product, there's always risk for an infection, so that preparing process is important. And because we are now bringing the inflammatory mediators to the surface, there's a risk of increase in inflammatory mediators. And so thus, the serum tears, while are protective and also promote corneal healing, they're not suitable for all patients when it comes to NK. So really isolating and identifying your patients is important. Next is the role of nerve growth factor, and St-Germain has been widely discussed in the past couple of years. Here in North America, in the United States, I should say, in 2018, the FDA approved an E. coli-derived recombinant human nerve growth factor, and the product is known as Oxervate. I've used Oxervate quite a bit in my own clinical practice, and we'll talk about some cases as to when it was helpful. And the way the dosage works is it's an 8-week treatment dosed 6 times a day, typically at 2-hour intervals. The patient administers the drop themselves, and really both in Europe as well as the USA, there were 2 clinical trials. I encourage you all to look up the trials, but the benefit of this was to see that in a large population, about 75%, I believe, from the US study showed epithelial healing on the surface in a very short course of time, not even leading up to the 8-week conclusion of the treatment. So Oxervate has been something that I utilize quite a bit in my practice. A side effect that's commonly reported is ocular pain. And the thought behind this is that while the growth factor is really stimulating nerve production, and the thought process is maybe the nociceptors or the pain receptors are reactivating, and so the feeling or side effect of ocular pain might be actually a sign that the drug is working. I included this photo here from thanks to one of my local drug reps that dropped off a sample care kit. So the way Oxervate is prepared by a Dompe pharmacy or Dompe and Accredo pharmacy here in the US, that the patient typically gets shipments on intervals of I believe every 2 weeks. And they're sent with vials, adapters, syringes, alcohol wipes, and the patient is really instructed on how to appropriately apply the drop at 6 times a day for a period of these 8 weeks. So number one is that the pharmacy is doing a great job and the company is doing a great job about encouraging access. While there's some paperwork involved, I've had some success with insurance companies covering Oxervate. And then third is also being able to coach the patient towards utilizing and in monitoring their compliance with the treatment. 6 times a day for 8 weeks requires a very special patient who's committed to their care. And so I think that this role of identifying a patient that will be a great candidate for Oxervate or St-Germain, it's important to identify good compliance. Next is intranasal stimulation, and really the goal behind this is activating the nasolacrimal reflex to increase tear production. And so there are 2 kind of aspects that this can be done. One is through physical stimulation through either electrical or sonic frequencies. There's products here in the US, True Tear as well as iTear, that are physically creating that nasolacrimal reflex response. And then most recently in the US, Tearvia, which is a product that was approved, is a pharmacological stimulator through the form of a nasal spray. And so it's a nicotinic acetylcholine receptor agonist that stimulates your trigeminal parasympathetic pathways. The studies basically show an immediate improvement in Schirmer scores, which is very telling because that's stimulating our lacrimal gland from producing more tears. So let's move on to some non-surgical treatments. So we talked a little bit about the role of oral systemic treatment, especially with the tetracyclines, looking at MMP activator inhibitors or blockers. Punctal plugs also play a huge role in promoting more tier meniscus in the ocular surface when tolerated. And I personally use silicone plugs in my practice, but collagen plugs are quite helpful. And if the patient has poor retention to the plugs, considering sending the patient for cautery is helpful. Tarsorrhaphy, whether it's a taped tarsorrhaphy or a partial tarsorrhaphy, can be helpful. Lid weights. This is a patient of mine that has neurotrophic keratopathy that had a gold weight that was implanted into the upper eyelid, inducing a partial ptosis, but also promoting a full complete blink due to loss of nerve control. And so this helped protect the ocular surface using the natural lid anatomy. Amniotic membranes and contact lenses, let's hold that thought and chat more about that. So amniotic membranes have shown quite a healing property on the ocular surface, and not just for NK, but also just for any form of ocular surface disease. So amniotic membranes are the innermost layer of the placenta. It's an avascular structure that's extracted and treated with antibiotics during the collection process. The twofold benefit of amniotic membranes is the barrier that acts to protect the cornea while it's healing, but also the properties of the basement membrane of the amniotic membrane. The collagen is very similar to cornea and the conjunctiva. And so as a result of that, there's better tolerance, and the stroma is containing all these anti-inflammatory markers that's stimulating more anti-inflammation and promoting more epithelial healing. Amniotic membranes can come in different forms. There's sutured amniotic membranes that can be placed in the OR. There's cryopreserved amniotic membranes that are typically stored in a freezer and then brought to room temperature. These amniotic membranes typically are inserted with a ring, as you can see from the top slide. And so inserted similar to a contact lens, and oftentimes comfort can be a little bit of an issue when it's first placed. And then dehydrated amniotic membranes, which are typically stored at room temperature. They're applied to the ocular surface, and the diameter tends to be slightly smaller than the typical corneal diameter. But then with that, it ends up being covered with an overlaying bandage contact lens, and usually takes about 2 weeks for the amniotic membrane to eventually dissolve on its own. And we'll talk about a case that amniotic membranes are utilized shortly. Next is the therapeutic role of bandage contact lenses. And I think here or in the US, the FDA has approved quite a few commercial lenses for bandage contact lens therapy. There's also the utility of quite a few off-label materials. Contour is a popular one used for keratoprosthesis. The goal is that we're looking for a large diameter lens with a high decay and wettability properties. But unfortunately, with a bandage contact lens, replacement is important. We always have to think about the risk of infection. Third is wetting defects or protein that can collect on the surface of the lens. And lastly, while it does help with short-term use of corneal healing, the thought is that because there's such a thin tier meniscus between the bandage contact lens and the cornea, it's not necessarily protecting the corneal surface long-term as compared to some other therapeutic contacts. So that segues great into scleral contact lenses. And so with scleral contact lenses, as you all can see from the image, there's a thicker tier meniscus. Depending on the fitter, we can see as variable of 150 microns all the way to 350, 400 microns. But that tier meniscus is typically a combination of saline or sodium chloride that's preservative-free in conjunction to the exchange of the natural tears that are bringing in your healing properties and your inflammatory or anti-inflammatory markers. And so with that, because there's a larger oxygenated fluid reservoir, there's a hydrated environment to promote the cornea from healing, but it's also preventing scarring, corneal desiccation, as well as vascularization, as long as the scleral is fit appropriately. Second is that because it's a rigid lens, it's acting as a physical barrier from the external environment. And remember, external environment can be as simple as the eyelids versus a dry environment or a foreign body. And this is important for NK patients because they don't have that natural response to blink when there is a physical concern for trauma. And so that acts as a protective barrier. And lastly, it's cosmetically friendly because with a lot of these patients, they'll be able to walk around their normal life with the contact on and also have the added benefit of potentially improving vision and stabilizing the vision. So economically, this tends to be a more long-term choice. And I encourage more of you to think about scleral lenses earlier on in the Mackey classifications, even as early as stage 1. Whereas I think traditionally when we think of scleral lenses, we're thinking of it as a last resort, and that's not necessarily the case, as we'll illustrate in some cases. So next, the goal is to really think beyond visual correction when it comes to scleral lenses. And some studies have shown that it attenuates pain and reduces symptoms. But in NK patients, pain is not of concern. So our concern is to support the ocular surface through protecting as well as lubrication. And that fluid reservoir of the scleral really acts as a therapeutic role in protecting and promoting the ocular surface from healing. Lastly, let's talk about some surgical treatment. So corneal neurotization surgery in general has been vastly used when it comes to peripheral neuropathy or nerve damage, whereas with the corneal neurotization, there's been various methods, ipsilateral versus contralateral neurotization, and the goal here is to transfer the supratrochlear and supraorbital nerves that are involved with the sensation of the eyelids and actually implanting them into the conjunctiva to promote the development of more nerves to help with nerve, ocular surface, nerve health and innervation. So a healthy nerve ends up being replaced, and this typically involves a large surgical cut. Now, there's also a role of indirect neurotization. So the two most common are sural nerves, which is coming directly from the leg, and the preparation of the nerve can elicit up to 25 centimeters of the length of a nerve graft, as well as the great auricular nerve coming from the ear. Lastly, there's also the role of cadavers, bringing up nerves as a potential graft, as well as acellular nerve allografts as well. So the role in all of this is, regardless of the graft that you use, the goal is to promote more nerve binding as well as development on the ocular surface to help with the corneal nerve. And the goal in this, while it might be considered a last resort, the results have shown some great long and short-term data as well. So let's kind of now chat and bring all of these topics of etiology, finding and diagnosing, as well as classifying, and now lastly treating neurotrophic keratopathy into some case discussions. And so the first case is all about healing wounds. This was a case that I had seen as I was a resident when practicing in Boston. So this was a patient, a 66-year-old male who had been referred to the Boston Foundation for Sight for a PROS scleral lens consultation. And his ocular surface included 8 retinal detachments. He finally had his retina attached at the point of examination. He did have a scleral lens, or a scleral buckle in place. He ended up going through cataract surgery and was left aphakic due to loss of visual function. He unfortunately, through the roles of different surgeries, ended up developing secondary glaucoma, and so was on some topical treatment for that. And as a result of that, was found to be neurotrophic in the left eye. Unfortunately, he developed a neurotrophic ulcer, which was treated in 2016, and then it recurred again in 2017. And as a result of that, he was left with a non-healing central corneal epithelial defect. So when the patient was being referred, he had been seen by quite a few different corneal ophthalmologists. And the last one that he had seen had brought up the thought of enucleating the eye. Since it wasn't providing any pain, wasn't providing any visual function, the role was to prevent the globe from perforating, to just remove the eye and think about a scleral shell instead. And so the patient was coming to us really as a last resort for this epithelial defect. So at the time of observation, the epithelial defect had been there for about 7 months, had really responded poorly to topical treatment, had multiple amniotic membranes that had failed in closing up the defect. And obviously this was all in the role of neurotrophic keratopathy. So currently the patient was on ofloxacin, which is fluoroquinolone antibiotic 4 times a day. He was using preservative-free artificial tears and was having bandage contact lenses exchanged every 2 weeks up to a month at a time, and he would travel back and forth between Boston, Massachusetts, and an outside state to have these contact lenses replaced. So at the time of meeting the patient, he had a corneal epithelial defect by 2 millimeters by 9. And what's classic in this case is these rolled edges. So this is stage 2 of the Mackey classification. And what you can see is there's parts of the epithelium, especially right here in the nasal quadrant, that is zippering closed. So there's an attempt of the epithelium from closing, but not completely. And of course, we're left with a large defect. So the patient was fit with a scleral lens and was encouraged to wear the scleral lens all daytime hours. And at his 2-week follow-up, surprisingly, his defect size had actually closed. And so you can kind of see that zippering of the epithelium closing in on that defect. And so we encourage him to continue the current role. And so at the 1-month visit, this defect size further decreased. Of course, because that epithelial defect had been there for a while and the patient had already had an ulcer in the past, we knew that the stroma was going to get some scarring, and the patient was hand motion in this left eye anyhow. So the goal was to simply eliminate the vision, but also just promote the ocular surface to heal. So the patient comes in again for a 3-month visit, and he had been alternating back and forth between a local provider and us in Boston. And at this point in time, unfortunately, you could argue that that defect looks worse, and there's an area adjacent that's broken down. And so this is a sign that just the defect is closed, that epithelium and hemidesmosome connection is weak, and so that epithelium can be subject to further breakdown down the line. And so at the 4-month visit, the goal here was that there was a concern of the neurotrophic keratopathy progressing to now stage 4. So what we can see here is there's about 50 to 60% of stromal thinning. And so there was a high concern of corneal perforation. The epithelial defect had also been there for quite some time now. And so the question was, at this point, when we take the scleral lens off, we have this rough epithelium, an epithelial defect, and this stroma that is very, very thin and at high risk for perforation. So the thought was, what are we missing here? Why is the patient not completely healing? And this epithelial defect had now been there for about 12 months. And while we were seeing some improvement from the initial presentation, there was significant thinning. And so the thought was possibly the patient was having some type of lag ophthalmos or nocturnal exposure. And so the thought was to consider a tersorrhaphy. But the patient was concerned about a tersorrhaphy because he was already having difficulty with insertion of pulling the eyelids, and a tersorrhaphy would limit his scleral lens insertion ability. And so at this point in time, we decided to initiate autologous serum tears with the role of an outside cornea provider. And the thought was to at least encourage a tape tersorrhaphy at night when the contact was removed, and to encourage the involvement of lubricants through the form of an ointment. And lo and behold, the patient comes in at his 5-month visit, and that epithelial defect is completely closed. Now, while the epithelium is still very dry and susceptible to injury, now we are successful in closing in that top layer of the cornea. And so really learning lessons from this case is that scleral lenses can be both protective but also restorative. It's important to always think about multiple roles of treatment. So it's not just going in by step-by-step approach, but tackling the management through various roles of treatment. Photo documentation is key to really monitor the course of the patient's progression with time, and close monitoring and co-management with ophthalmology colleagues is important in the successful role of this patient's recovery. The second case is staying without pain, which is classic in NK. So this is a 50-year-old female that I met a few months ago. She had a recent hospital stay where she didn't have access to her traditional artificial tears. And so she was presenting for an emergency visit with some blurred vision and redness in an eye that normally sees about 2150, but she was count fingers vision. Her history includes a neurotrophic ulcer that she had few years back due to a trigeminal nerve damage due to a brain tumor resection that was done in the brainstem area. And so the patient currently was using preservative tears 4 times a day, but was concerned that something else was going on. So diving into the patient's history, she had a brain tumor lesion Here's her etiology, removed in 2013. And at the time when the brain tumor was found, the patient actually had ocular symptoms, so diplopia and exotropia. She also had a partial ptosis, so there was a concern of the carotids being involved, eliciting this hornerus. And so she developed a neurotrophic ulcer that healed, but it left a very large central scar, and that's where her vision was around that 2150 range. In 2018, to promote tear meniscus and tear lubrication, plugs were put into this eye, and the patient was using and very diligent about artificial tears as well as an ointment at night. So unfortunately, this hospital stay eliminated her ability to access the lubricants that she needed. She's also a high myope and wore spectacle correction full-time over top to protect her eye, especially since she's monocular. So at the time of the clinical presentation, I apologize I don't have photos, but she had a 4.5 by 2.5 epithelial defect with the same classic rolled borders. And so the thought at this point was that she had a epithelial defect secondary to neurotrophic keratopathy, stage 2 for the Mackey classification. There wasn't a concern of an infection at this time, and so she was put on a topical preservative-free fluoroquinolone, started back up on her tears but on a more frequent dosage, and started on ointment. And so when I saw the patient back at the 1-week follow-up, this was her epithelial defect in size. So again, she has that old large central scar, and within that scar she has this epithelial defect. What was unique in this case, though, was the patient was quite injected and was complaining of some deep pain. And so the concern at this point was that, is this an ulcer and not just an epi defect? And so the patient was cultured for etiology. She was also started on an antiviral Valtrex to cover the herpetic background, potentially, continuing the antibiotic, reducing the dosage to 4 times a day. And at this point in time, a bandage contact lens was placed to promote the epithelium healing. Due to the contact lens, I actually stopped her ointment because my concern was the contact would shift around with a thick viscous solution. So at the 2-week follow-up, the patient comes in and her epithelial defect is reduced in size. This is an image of the contact lens on the surface. There's a little bit of a bubble after I applied it. But the unique aspect of this photo is the roll of fluorescein as it sat on the surface and spread past those borders. At the time, the culture results ended up coming back as a gram-positive, and so we switched the antibiotic to polytrim to cover more of a gram-positive bacteria, and she had completed her course of her Valtrex, was having some side effects systemically with the Valtrex, so we decided to halt that antiviral treatment. And so at this point, the patient was on bandage contact lens replacements every 2 weeks. At the 6-week follow-up, she had further improvement where now this epithelial defect was slowly closing in size. So we continued the same treatment. And I'm happy to say I just saw her last week for her 8-week follow-up, and that epithelial defect is completely closed in size. So while the epithelium defect is closed, you can see that that surface is still very rough, and that epithelium is easily prone to injury. And so the thought now is, now that we've healed the cornea, how are we going to protect and promote the cornea from breaking down again in the future? And so that at this point, we'll be starting a scleral contact lens fitting process to really protect and preserve the ocular surface. So if we think of the timeline of this patient between topical therapy, the role of bandage contact lenses, to then healing the ocular surface, we're able to differentiate stage 1 Mackey classification down to stage 2, prevent the leading into stage 3, and now the goal will be to promote the surface from breaking down again in the future. So learning lessons from this case is the importance of maintenance treatment for the ocular surface, the importance of culturing, simplicity of bandage contact lenses when it comes to the role of healing the cornea. And next, let's lead into time heals all wounds. So this third case is a 62-year-old patient that had history of NK that was known. She had history of amniotic membranes placed twice due to recurrent epithelial defects. And she was on a short course of Valtrex, but that was discontinued after there was no concern for HSV. And so at this point, when I met the patient, she was having bandage contact lenses that were replaced every month. She also had punctal plugs placed into the eye, and her routine with the lubricants and antibiotics was very good with compliance. Her history, unfortunately, involves some surgery. So status post LASIK in both eyes, ended up having a retinal detachment that also redetached twice. She developed an epiretinal membrane, ended up developing a secondary cataract, and bad luck with that cataract too, because the eye wall dislocated. So they went in again and attached the eye wall to the sclera. And at this point in time, the patient developed bullous keratopathy that was treated. However, all of these point towards NK. So the role of LASIK all the way down to all of her multiple surgeries. So as far as testing, when I first saw the patient, her Schirmer score was reduced to 3 millimeters in both eyes, which is not surprising considering she had refractive surgery done. Her corneal sensitivity, so I did the con thread method, and here she actually had a normal response in all quadrants in the right eye. I was expecting her to be slightly reduced because of her history to the LASIK, and surprisingly she was not. But in the left eye, she was absent in all quadrants, which confirmed my NK suspicion. So staining with the fluorescein, and this is what we found. So at the time where the patient actually presented to me, the patient was informed by her previous provider that her epithelial defects had healed. And interestingly, I removed her bandage contact lens, and this is what I found. So she had multiple epithelial defects, and I understand why, the thought of herpetic etiology might have been thought in the past, because this could theoretically look as like a geographic lesion as well. But the key in this is that applying the fluorescein and watching and waiting. And what you can see is from those franked rolled edges, the center border actually shows some loose epithelium on the edge, to then that slow leak of the epithelial of the fluorescein kind of shows this neurotrophic aspect. So rather than actually going ahead and fitting her in a scleral lens, my thought process was, let's heal up the cornea. We've tried amniotic membranes, we've tried traditional therapy with the lubricants, and we are on a bandage contact lens, so let's try Oxervate. So the nerve growth factor was initiated 6 times a day for a period of 8 weeks. It's encouraged to remove any type of amniotic membrane or contact lens to allow improvement in penetration of the drug on the ocular surface. So I removed her bandage contact lens, and she was using tears very frequently. And then the long-term goal would be, after her cornea would heal, we would protect it and preserve it through the role of a scleral contact lens. So this was the 3-week follow-up after initiating Oxervate. As you can see, those epithelial defects are much smaller in size. This was the 6-week guideline, where now her epithelial defects had closed, but there was that epithelial ridge forming. And then the conclusion of the Oxervate still showed that epithelial ridge, kind of that diffuse scarring that she had had with the stroma being very hazy, but also punctate staining, indicating that the surface is still susceptible to injury and damage. And so at this point in time, she was fit with a scleral lens, and I pulled out all my tricks. I fit her in a large diameter lens. I put fenestrations into the lens to limit suction, made sure that she had a good tear meniscus height as illustrated in the slit lamp photo. And 1 month post-scleral lens wear, we actually saw slight improvements. She still had that epithelial ridge. The pro was that she did not have any epithelial defects, and slowly but surely that ocular surface was healing further. 3 months post-scleral lens wear, we see that we're actually seeing an improvement in the clarity of her cornea, and that epithelial ridge is present. It's elevated and irregular, but also not staining as much. I just saw this patient back right at the end of 2021, and this is what our ocular surface looked like. So she wears her scleral lens about 12 hours a day. She does use ointment and lubricants throughout the day as well as at night. And removing the scleral lens, look at how pristine that ocular surface looks. We have no epithelial defects, and that surface is really smoothed out. And we'll argue that that pupil in the view is also slightly clearer. So at this point in time, she has dense YAG capsulotomy. She's working with ophthalmology to consider maybe removing the PCO through the form of YAG capsulotomy to see if we can help improve the vision a little further. So learning lessons from this case is the importance of staining, the value of nerve growth factor in topical treatment of therapeutic healing, the adjunct role of scleral lenses in ocular surface preservation, and really the importance in this is monitoring the patient. Patience is a virtue. It took some time, almost 6 months, for us to see an improvement, but documenting that and following the patient was very important. Last but not least, this case is one size fits all, or does it? So this is a case of a patient who was 62-year-old female who was coming in for an emergency visit, and she presented with redness, blurred vision, and light sensitivity. Her history includes, of course, some surgeries, but also a herpetic HZV in her left eye. And she was recently seen at an outside urgent care, was told she had a corneal abrasion, and they applied a corneal Band-Aid on the surface. The patient ongoing had medications of Valtrex to cover her herpetic background, prednisolone due to some corneal scarring traditionally, as well as preservative-free artificial tears. And so when I met the patient, I removed the bandaged contact lens, and this is what her cornea looked like. So she actually had an epithelial defect, and while she was diagnosed with the corneal abrasion, the epithelial defect was improving. And so at this point, we replaced the bandaged contact lens and actually inserted a punctal plug to promote more tear meniscus. Her vision at this visit was count fingers. So she comes back a few days later, and now the epithelial defect has now become this ovoid defect. It's reducing in size, and we're seeing some improvement. And so at this point, we replaced her bandaged contact lens again. She had some deposits on her original lens, and we encouraged her to do an eyelid taping at night. By day 7, unfortunately, her vision was worsening, and she actually had a worsening defect in size. No evidence of an infiltrate, but now it's a mild stromal edema. And so the thought at this point was NK is our culprit. This is not just an epithelial defect due to an abrasion. So with the aid of a colleague, a corneal ophthalmologist in my practice, she was had an amniotic membrane that was placed with a bandaged contact lens over top, and our provider had also done a temporary partial suture tarsorrhaphy to promote more eyelid closure. So by day 14, we had some improvement in the vision. It was hard to visualize the cornea through the amniotic membrane, but she was improving nonetheless, and so we continued her treatment. We had also switched her from the prednisolone to the fluorometholone, going to a softer steroid to help promote the corneal epithelial healing. And so by week 4, her epithelial healed completely, but she was at high risk for an epithelial breakdown. So that's where I was involved with putting her into a bandaged contact lens that she could be in more long-term. So I decided to go through a contour lens, which is more of a conventional off-label lens. And so at week 5, she showed some improvement with still some corneal staining. She had her tarsorrhaphy removed, and at this point, the bandaged contact lens was applied. By week 8, she still had this coarse epithelial irregularity, and I was expecting it to be much improved with the bandaged contact lens. And at this point, we were also noticing a paracentral defect forming very early. And so the thought was now remove the contact and start her on Syngerman, or our nerve growth factor. At this point, the patient went through her first round of Syngerman, and her vision astonishingly improved to 20/50, back down to her baseline. Her epithelial defect had healed, and she still had some residual epitheliopathy. And so at this point, the patient, interestingly, was approved for a second course. This was done right in around 2019, 2020, where there was not that much evidence with second course versus a first course of oxybate. And so at this point, the patient was seen about 6 weeks into her second course, and unfortunately, her vision had declined, and she was showing some new signs of vascularization. And so the decision was made to stop oxybate, and we fit her with the scleral lens. So here I thought I came in with a knight in shining armor with my scleral lenses, and I fit her with a contact lens, large diameter, with some fenestrations in the haptic to really limit suction. And when the patient was first seen, you can appreciate from this OCT, the epithelium was very rough. But overall still healed. But the patient called in a couple hours later and said, Dr. Dave, my vision all of a sudden is much blurrier. So she came in, and unfortunately, at this point, she developed an epithelial bullae about 4 hours after wearing the scleral lens. And so with that epithelial bullae, we were able to see it underneath the scleral. And when I removed the scleral lens, that area where she had the original epithelial defect had now had that poor hemidesmosome connection. And no matter what I did to the scleral lens design, with any tricks, fenestrations, channels, changing the diameter of the lens, she still continued to develop bullae in about 3 to 4 hours of wear. So unfortunately, she failed with the scleral lens. And so the next thought was, let's put her into a bandage contact lens now that she's completed her Oxervate. And we tried different types of bandage contact lenses, high DK, high water content. Unfortunately, the patient continued to develop neovascularization with any 24-hour bandage contact lens that she wore. And immediately when I would take the patient out of the contact lens and have her do a trial for 2 weeks after, those vessels would regress. And so at this point, even a bandage contact lens was creating hypoxia for the surface of the cornea. And so at this point in time, the patient was just seen in our clinic a few months back. She's stable. She is nervous about contact lens use because she's tried multiple roles. She does have a Dailies Total 1, which is a high DK daily contact lens that she wears if she's traveling, getting on a flight, or in a very dry environment. But otherwise, she's keeping up with her artificial tears. She has her plugs in place, ointment at night, and she does a taped hirsutherapy. And so in all of this case, what we're seeing is that we're closely monitoring. That's her cue to say something is off and she needs to get into the office because she doesn't have that pain response as seen in neurotrophic keratopathy. So the patient's holding up well and she's being seen every 3-4 months. So learning lessons for this case is always consider NK as part of your differentials. Always monitor for vascularization with any role of treatment. Contact lens therapy, while I've shown some cases that it's worked very well, it's not suitable for all patients. And so really sometimes simplicity is key through lubrication and topical therapy as well. So to conclude with this lecture, what I'm hoping is that everyone can understand the etiology, that there's multiple causes of trigeminal denervation. And so at that point, really isolating and identifying your high-risk patients for NK, then screening those patients through various tools, whether it's the dyes or the sensitivity fat testing. Earlier diagnosis will prevent the disease from progressing and ending up in your chair with a perforation or an ulcer. Treatment is all guided towards the classification, so restoring, regenerating, and protecting and preserving the ocular surface. And lastly, management. So really thinking about combination treatment to determine the appropriate treatment that's going to be accessible, affordable, and efficient for your patient. And of course, all this is driven by disease severity. And so with that, I'm going to conclude the presentation. Here are my references, and we'll open it up to some questions.
Awesome. Great. So thank you so much, Dr. Dave. I think that was really wonderful in terms of getting us through what is the importance of the condition. And also, most importantly, I think we learn more from your case studies and experience. So we know not to follow most of the things, but what not to follow, what not to, make sure that we don't end up doing the same things and help our patient much more. So it's good to learn from those case studies.
There's no cookie cutter method with any ocular surface disease condition, but even especially with NK, there's multiple roles. And so again, through successes and my failures, I hope that the audience has learned quite a bit.
Thank you. Yeah, I am sure that happened. And the first question which came in asked about, you said about the corneal sensitivity measurement and the importance of these, and you also introduced us with 3 different methods or techniques, if I may put it that way, to evaluate those. Which one is considered to be the safest, and which one is your favorite, or probably which one do you perform the most?
Sure. So I'm going to argue that all 3 are safe for the ocular surface because if they weren't, then they would not be done. And I do think that while there's benefits to the cotton thread sensitivity, for example, it's easier access. We all have those cotton swabs in our office, and to really just pull out a filament and check for sensitivity is helpful. The disadvantage is that you have to really do the testing frequently to understand or elicit a normal response, and it's more of a subjective reaction. So that's where I think the Cochet-Bonnet instrument, which is available through many manufacturers, and it's not an expensive device by any means, can give you more of a quantitative measurement. And I think with all of us being clinicians, we're numbers people, and whether it's staging or grading, my preferred method, to be honest, is the Cochet-Bonnet, because then I'm taking out my own subjective bias when measuring it. With the gas or non-contact aesthesiometer, I haven't had much experience with it. I know that there's various models and a lot of studies that are utilized with it. So for me, it really just depends on, are you checking for corneal sensitivity? If you are, then any of the three methods can be suitable, and as long as you have consistency in measuring it. So to use a con thread method at one visit and then to use the Cochet-Bonnet at a different visit may not be accurate. So to keep consistency in the testing and really determining what method is most preferred by you. And in my case, I don't have access to the Cochet-Bonnet on a regular basis, so I'm reaching out for my con swab most frequently.
That's right. But the most important thing, I think, is at least start to, test for corneal sensitivity, because as we saw in the polls, a lot of us really don't do that on a routine basis. So it's always good to know. And that's the important message I think you are trying to put it across, that is something which we need to incorporate into our clinical practice while managing these NK patients.
And I will say also another aspect when we're thinking of our objective testing too is that, in the practice that I work at in Buffalo, we have technicians support our clinic flow. And so technicians oftentimes are practicing a lot of these objective measurements, whether it's pupils or tonometry or a visual acuity. And so either training your staff to measure the corneal sensitivity and or doing it yourself, but to be aware that if the technician has already anesthetized the cornea for applanation or tonometry measurements, it's going to throw off your measurement. So if you're suspicious for a patient that has herpetic disease or post-LASIK or refractive surgery or corneal abrasion, instruct your staff to not check for tonometry or IOP so that you're really getting the true measurement, and involving your staff, because not necessarily every test is supposed to break down your clinic flow. It can just be adjunct and helpful towards more efficient care of your patients.
Yes, that's right. And another question is, can recurrent photoophthalmia cause neurotrophic keratopathy, or is it interrelated in some way?
I think that this can be interrelated. And Umar, this is a great question, because I think that there's also an importance in differentiating neurotrophic keratopathy versus corneal neuralgia. So we often think of neurotrophic keratopathy as stain without pain, and corneal neuralgia as pain without stain. And so photoophthalmia or recurrent photoophthalmia can be present in both scenarios. And so I think it can be interchangeable. And the goal is again, looking for corneal sensitivity, looking for the dyes, and being able to manage that patient long term.
That's right. Yeah. And one more question is again regarding the scleral lenses. So you said that in these cases, scleral lenses are more of a therapeutic use compared to the vision part. We are more concerned about using scleral lenses as therapeutic measure. Is there anything different in terms of fitting lenses versus a vision correction? So do you do something different when you fit scleral lenses for NK versus a refractive procedure?
So to be honest, no, because the only aspect that I am not necessarily concerned about with NK, not to say that I don't check it, is my over-refraction to determine the front surface optics of the lens. But the actual fitting techniques, making sure we have an appropriate tear meniscus, making sure we don't have impingement or blanching of the vessels, ensuring that we don't have any post-lens staining, edema, IOP spike, or central corneal thickness spike. Always taking the lens off and looking for staining is important. And then, various diameters will be helpful. And I know we've had many of my esteemed colleagues lecture on scleral lenses just on this OOLS platform. And what we can see is that there's no uniform opinion. Some prefer large diameters, some prefer smaller diameters. Depends on the patient, depends on the case. It also depends on what commercial lenses or custom lenses or empirical lenses you're designing. Now, scleral lenses can be really manifested through 3D imaging and corneal molding versus using a diagnostic lens. And so now there's more imaging that's involved in producing the most accurate lens. And so whatever your route is, for me, whether I'm fitting a patient with keratoconus versus fitting a patient with a neurotrophic keratopathy or ocular surface disease, my fitting techniques are the same. The only difference is going to be the isolation on the optics of the lens or the vision aspect. Now, what I will argue is that with some of these patients that have corneal scars, the long-term evidence is that some of these corneal scars can reduce in density and improve in clarity with scleral lens wear. And so I think it's important to always still check for vision and check for improvement in vision, even with your NK patients, because over time, we might actually be able to restore vision, which is an added benefit to promoting the ocular surface from healing.
Awesome. Great. And another question is asking about the percentage of patients. So how many routinely do you see NK patients, and is it quite common in some areas, or anything related to that sort of ethnicity or something like that, if you want to comment on that?
Sure. So again, it goes down to etiology and risk factors. So if there are certain communities where diabetes is vast and that systemic condition can create neurotrophic keratopathy, one would argue that in a diabetic population, we have more neurotrophic keratopathy. For me, practicing in both countries, I don't see an asymmetry. I do, work in a specialty contact lens practice. And so a lot of the patients that are coming to me are post-LASIK, post-refractive surgery, post-herpetic disease. And so they're already having risk factors more than my typical -2 myope coming in for a cataract exam. And so for me, I feel as though I am diagnosing and actively treating about 5% of my own clinical cases to neurotrophic keratopathy, but I bet you I am still underdiagnosing and undertreating it. And so what I'm really doing as my own effort this year is to start involving corneal sensitivity measures earlier on in more standard screening of patients. I am currently only doing it in patients that I suspect NK, and I'm seeing stain without pain. I'm moving that slit line and thinking, oh my God, how does the patient not feel this? And that's when I'm pulling my corneal sensitivity. But my goal for this year is to involve it in more of my objective testing for a lot of patients that have risk factors as simple as contact lens wearers or post-refractive surgery or a patient that has a vitamin A deficiency. So I think that my percentage is not accurate, and it's probably going underdiagnosed even in my specialty contact lens and ocular surface disease practices.
That's right. And I think your explanation about etiology helps here a lot when we look for, the risk factors. So now we can go back into practice and see, okay, these patients are probably at a higher risk, and now start, evaluating and see how much.
Or just simply checking corneal sensitivity. And then that way you can help differentiate NK from just normal patients.
That's right. And at what stage do you think considering a topical steroid in the treatment would be your consideration? When would you want to do that? Yeah.
So for me, that's typically in stage 1 of the Mackey classification, when I don't have a frank epithelial defect. And I find that topical steroids are very helpful when it comes to reducing inflammation, which plays a key role in ocular surface preservation. So for patients that I start on cyclosporin therapy or lifitegrast, I'm oftentimes using or combining the therapy with a short pulse dose of a topical steroid. However, a lot of my patients, for example, those that have herpetic disease, that have some type of corneal stain, corneal scarring, are on topical steroid treatment to limit flare-ups. And so while we know steroids are contraindicated in epithelial disease, in many cases, the topical steroid can limit flare-up control. There's a product that in the past couple of years just recently got approved. It's loteprednol at a 0.25%, I believe. Isuvis is the brand name of the product, and it's low-dose loteprednol that's used for flare-up control for dry eye patients. And while it's important to differentiate dry eye patients from neurotrophic patients, I think that utilizing it when reducing ocular surface inflammation is crucial towards preserving the ocular surface and preventing it from breaking down into stage 2.
Okay, great. NK probably is also associated with Bell's palsy, or Bell's palsy causes NK. Have you experienced that? Do you see such patients?
Yeah, so this is where I've had this discussion quite a bit, because I've fit many patients with Bell's palsy for scleral lenses to protect their cornea. And so the question becomes, is the patient having this facial palsy that's creating exposure of the cornea? Because there's exposure of the cornea, there's corneal breakdown. And as a result of the corneal breakdown, the patient's becoming neurotrophic. The other side of it is that depending on the etiology of the Bell's palsy, is the trigeminal nerve also being impacted, which is therefore causing reduced neural sensitivity on the cornea. So I think both exposure keratopathy as well as NK do go hand in hand. I showed a picture earlier of a patient with a gold weight in the eyelid, and this was a patient that had both exposure and neurotrophic keratopathy secondary to a Bell's. And so the gold weight was really helping in the eyelid closure, but I ended up fitting him with the scleral lens just to protect and promote the healing of the ocular surface even more. So I do think that both can go hand in hand, and the goal again is to look with corneal sensitivity. And I agree with whoever commented on that there's a lot of comorbidities associated with NK.
Awesome, great. And let's just take one last question before we end for today. When recurrent corneal abrasions occur, there is also a reduction in the corneal sensitivity. What's your thought process? I know it's related more of to the pathophysiology, but I'll just let it come in and get your thoughts over it.
Sure. So we mentioned this a little bit earlier with the pathophysiology of the epithelial cells, and the turnover and mitosis of the epithelial cells are largely driven by trigeminal nerve innervation. But when we think of a recurrent corneal abrasion or an RCE erosion, we have that poor hemidesmosome connection to the epithelial and basement membrane. And so with that turnover, we're getting that breakdown of the epithelium. And as a result of that, the epithelialization takes some time and process to occur. So it's a cyclical process where we have the epithelial breakdown through some type of friction or poor hemidesmosome connection. We're depending on the trigeminal nerve to stimulate the mitosis or the propagation of epithelialization, but also the trophic factors that are helping to promote the epithelial proliferation and healing. And then again, we have that breakdown again. And so that cyclical process then eventually causes corneal sensitivity to decrease, which is a combination of how that trigeminal nerve is so crucial towards stabilizing the ocular surface.
Awesome, great. So I think with that, thank you so much, Dr. Dave, for that wonderful talk and sharing your experience.
Absolutely, it's a pleasure. And thank you to OOLS and Fakhruddin for your efforts. The goal is for us to all continue to learn and share. And so through the world of COVID, it's been a past couple of hard years, but we're thankful for online opportunities to connect the world this way. And so thank you, OOLS, for those efforts.
You're most welcome. We do have session planned next weekend. Until then, take care, be safe. See you next week. Bye-bye. All right. Thank you, Dr. Dave, for that.
Oh, no problem. That was great.